All right, let me begin by introducing my colleague. So to my right is Bo Crowell. Bo is the head of healthcare services at Macquarie Capital, the corporate advisory to the markets, principal arm of investing, more than 20 years of experience in the healthcare industry. And he joined from UBS in 2018, and he was a managing director there. So he has deep sector experience in the healthcare services and technology. So give a warm welcome to Bo.
Henry, thanks. I have a quick question for you, actually, before we get started.
Can I get $100?
No $100, but I'm a little bit confused. I thought we were here for an MSA conference, Metropolitan Statistical Area. What the heck's a healthcare MSO?
We'll get into it in MSO. Okay, Hugh Lytle. Hugh is going to talk about with us. He's with Equality Health. It's an Arizona-based healthcare delivery system focused on improving healthcare delivery for a diverse population with culturally sensitive programs that improves access to quality and member trust. Through an integrated technology and service platform, he's a competent provider in the network and a unique culture care model. So he'll tell us a little bit more about himself and that when we get into it. What I thought I would do is to kind of start off and tell you a little bit about myself and what we see in the market, and then we'll switch it over to kind of a panel discussion. So I'm in I'll say the physician healthcare market business. We're an investment banking boutique firm. I founded in 1990. And all I do is work with healthcare providers and facilities. We did $1.2 billion last year of closed transactions, and we're seeing many different types of transactions. So I know we're here today to talk a lot about private equity, but I will tell you that we're seeing transactions happening with health systems. And I say what's next? Well, we see Amazon and Walmart, coming over into the healthcare world. We're doing some interesting things to evaluate options. For example, how many are you familiar with ESOPs? Okay, so there's a few of you. My company is an ESOP, so we created it about 4 years ago, and we are now entering into the healthcare market doing ESOPs. And this is a way to give a physician full autonomy, keep control of it, and pull out some money, and we might explain a little bit more about that later. I also see systems like we're working with Advent, which owns Florida Hospital. They're one of the largest providers to CMS. It's a huge system. They got very, very aggressive last year in acquiring practices, St. Barnabas in New Jersey. So there's a lot going on. So what I'd like to begin with is to ask my panel, what's the most significant driver of the change from your perspective, Bo?
So I think a couple of things. I think you're seeing just the complexity of healthcare in terms of not only sort of regulatory, payer, revenue cycle management, technology, all of those things, but also now with consumerism in healthcare, digital marketing, and all the things it takes to drive referral sources. I think a lot of this complexity is really driving the need to create these platform companies that can help physicians really better manage their business, but more importantly, allow them to spend the time doing what they do best, which is delivering care. And so I think an MSO platform type model can help them deliver and create a lot of that value through a business perspective, while the physicians can focus on really the delivery of care and delivering better outcomes and that sort of thing. And then on top of that, and I'm sure Hugh will give us a lot of great color on value-based care and that impact on the volume of deal activity we're seeing, but I think that's going to be a big driver as well.
Okay, you?
Sure. From more of a commercial market perspective, I would say the opportunity is really driven from payment reform that goes back to getting off the fee-for-service system, which really created this entire, I think, MSOs existed, but they were really in states where capitation had already existed or had been experimented with. But under the new reform, payers are coming up to speed faster, and we are moving to a place where there has to be this intermediary that sits between payers and providers to help really move this along faster, and that's why it is more of a platform opportunity, because there's so many components to that that I'll talk about.
Great, thank you. I'd agree with both of you, but I would add to it, I believe what's driving this significantly has a lot to do with the financial impact. Physicians are looking to unlock some of that monetization and try to free that up. And with the uncertainty on the horizon and not knowing what's going on with the payer system, don't be fooled. They're not doing this just to do it. And where I believe it's going to value-based care and data analytics is going to be so important in the future. But I will tell you, it's about growth, and it's about physicians trying to pull some of the money off. That's my own personal opinion. What sectors do you guys believe will be the hottest in the next 12 to 36 months?
You want me to start?
Yeah, please.
So we've clearly seen a lot of activity across multiple physician specialties, urology, orthopedics, vision, dermatology. I think one area that's been underrepresented, and we at Macquarie are spending a lot of time, is in the primary care world. And you look at the number of private equity-backed platforms and some of these other specialties, and it's substantial. But on the primary care side, the numbers are just far less, and there's a lot of primary care providers out there relative to some of these other specialties. I think historically, people have looked at primary care and said, you know what, there's just not a lot of dollars in the business, and so it's harder to see where the value can be created is. But I think now with multi-specialty models, with models like concierge medicine, concierge light or direct primary care, and then you have all the value-based models being driven by the reimbursement reform that Hugh was talking about, I think it's just going to create a really interesting opportunity in primary care, and we're at the very early stages of a lot of that activity.
Yeah, I'd agree with Bo. Obviously, primary care's power of the pen has a lot to do with how the costs end up rolling out. So we believe heavily in that model, and we'll continue to see a lot of interest. I'm not an industry guy, but per se, but just from an M&A perspective, we look at primary care, we look at HIT, technology to be able to reduce the amount of labor that exists in ambulatory care that's required to service a population. And then, lastly, just as Bo mentioned earlier, member, consumer, patient engagement. Activation of members is finally, the pot's finally getting close to boiling, and there's a lot of new promising things coming that way.
So we've seen we did the largest transaction last year. To date, it's the single largest urology deal in the country. It was 110 physicians with one tax ID. We just added another 15 physicians, and by December we'll be up to 170 urologists in one state. And the growth of that has been incredible. But what I'm seeing in the future, I'll say the primary care is a little too sophisticated for me because it is a lot of data analytics. So we've been working with I'll say the low-hanging fruit, doing a lot in neuro, spine, orthopedics, ENT. You're going to hear a lot about coming in the future. So there's so much business. It's so frothy right now. There's a lot to do and a lot of opportunity. How does value-based care change the landscape from your perspective, Bo?
Well, I think it's like an oncoming tsunami, I think, in terms of what's going to happen to the landscape. And I think we've been talking about it for 20 years. There's been various programs started and stopped by CMS in terms of demonstration projects, but I think there's been a real private market acceptance and adoption of value-based care. Right now, we're seeing it more in sort of the Medicare world and Medicare Advantage world. CMS has come out with a new kind of proposed demonstration project on allowing primary care docs in a fee-for-service type environment to have similar sort of value-based arrangements. And I think from there, we're starting to see it move into the commercial world as well. So I think it's going to impact the landscape tremendously. It's difficult, it's not easy, it's going to take a long time to really play out in terms of a wide scale. But I think it's the real way we're going to unlock a lot of better outcomes, drive lower costs, and really substantially bend the cost curve in healthcare. And it's one of the ways we can fix healthcare in the US is by really realigning the incentives between providers, consumers, and payers, and I think value-based is going to be one of the big drivers that make it happen. Hugh's the real expert, though, so he'll give a far better response.
Thanks, Bo. No, not really. I think this is transformational. If you've been in healthcare, like most of us have forever, it's follow the money, right? And this is a huge transition as as payers begin to share that premium with people who can actually put it into action in a right way. And you said it earlier, physician compensation. I think it's an exciting time for the industry and those professionals to be able to capture and realize the gains of what it means to do that. Now, it requires a lot of changes. It requires workflow changes. It requires different ways to approach your business. And that's what we're here for as an MSO. Value-based our business model, for example, wouldn't exist without it. So you could not do Medicaid transformation under a fee-for-service Medicaid system. It's just not possible. But by being able to shift premiums to allow us to make investments into the population, into whole person health, allows for us to advance the healthcare system, and again, couldn't happen without those dollars.
Well, some of the clients that we're working with right now are doing fully capitated. They're working with CMS. They're shared savings. And when you look at the amount of money that they're making, because they understand it, it's huge that they're able to save the system as well as make money for themselves. In the transaction that we recently did, we also determined that there was a need for data analytics. They spent $6.5 million and signed a contract with Epic to change their whole system. So that to get physicians to commit to spend that kind of money is unheard of. But it took a group of 100+ physicians to decide, hey, we really need to make an investment in the future. So we'll see, stay tuned, what happens with that. How to implement a new MSA model for the country is a little bit of the focus. What's the role of the MSO in population-specific healthcare?
So if you're going to be an MSO, at least the way we see it at Equality Health, in the future, you have to understand population dynamics. You have to be able to look at population health, not just on the analytics side, which has traditionally been, generally age, sex, chronic disease adjusted. You got to look at it more broadly. You got to look at demographics. You got to look at the changing of America. We talk about the graying of America, very important, but so is the diversity that's changing. And we have large subsegments of our population that don't engage the healthcare system in any kind of a meaningful way or understand it. So what I believe is you have to start with a good understanding of your market, your local market, and a good understanding of your patient base. And so we do big data analytics before we begin. We broke Maricopa County, which is Phoenix, Arizona, into 6 underserved districts based on census data, based on socioeconomic data, based on access to care, quality of care, CDC indicators, et cetera, so that we can map the population and understand where we've got neighborhoods where literally nefarious businesses, you'll have a liquor store across from a title loan, across from an auto loan, center, all in one community. And so these communities have a tough way to go for healthcare, and so you have to look at the whole person needs. You have to be able to look at not only their physical health attributes, but their behavioral needs, as well as their social determinants and/or community barriers that they've got to be able to engage and access care. And that's what we do at Equality. We consider ourselves really an organizer of that delivery system of care. So we really, what we do is we put the pieces together so that we can help ethnic and underserved populations better access care, and we help the payers both better engage and drive out health outcomes for what are really their most vulnerable populations. And we do that through a very doctor-patient engaged, advancing that doctor-patient relationship through some things I'll talk about later.
Yeah, that sounds terrific. Bo, what's would you say is the driving increase in the activity in the MSO?
I think it's a number of things. I think it's a lot of what we've talked about in terms of increasing interest in value-based care, the increasing sophistication of these platform models. I think working with physicians to really help them understand how to drive value with their practices in terms of adding ancillary services, adding new geographies, creating density in a market so they can do better with payers and contract in terms of getting better rates. I think there's a real recognition, I think, as you alluded to, Henry, in the physician community, that these platform companies can really help them do a lot of things they're struggling to do on their own. On top of, as you said, sort of the ability to monetize what they've built in their market and deliver value for themselves, but also create value moving forward. I think there's been a real recognition that these models are working. They're creating value for physicians, for the investors that are looking at them. And you look at the physician universe in the United States, and it's still very, very unconsolidated. You can go specialty by specialty, but for the most part, there's still tons of independent groups operating out there. In most cases, it's under sort of 20% of these physicians are in a platform MSO type company. And so there's just a real opportunity, I think, and it's one that's going to exist for a long time. And so it's attracting, I think, a lot of interest from the investment community to help drive a lot of that value.
And I would agree, and I agree with what you has mentioned. Without the data analytics, I want to say it's valueless long term. You need that information to be able to go forward, and I don't see the small groups or individual physicians being able to do that without aggregating, consolidating, and coming together. So we're seeing a lot of that, and it's not a dirty word, not just for the money, but for the growth. I would say a lot of people are coming together to grow, and there's real economies of scale. Where do the MSOs need to evolve to support the payers and providers in a full risk situation?
Well, you hit the nail on the head right there when you said the independent physicians. So if you're a health plan, 50% of your costs come from all your independents. So while the large groups you can dial into an Epic, you can trade information with a payer if you're a large, and negotiate heavily with a payer if you're a large physician group. The small guys struggle, and that's where we do a lot of our work. We aggregate independents and basically allow them to act as a single group, not just in a messenger model, but in a much more comprehensive way. So the way it needs to evolve, I believe, is that you have these deep variations in MSO. You have a variation that's more physician-owned or physician-centric, and all employed docs of an MSO. Or you have a network IPA model, or you have in California, you have more of a financial fiduciary role. What what needs to change is, I think, to support it over the long haul is really a 50-50 hybrid approach of part payer, part provider. And that's kind of how we've set up our MSO. So on the provider side, since we do have a lot of independence, we really focus heavy on practice transformation. So what that means is we instead of being a rep and showing up and dropping off a quality report and saying, hey, you're not doing very good, we're going to kick you out of a value-based contract, or you can't get into a value-based contract. We work hand in hand with that practice and we hire only former practice managers, people who really know the ins and outs of the practice, and we train that practice. We train them on cultural competence. This is our own curricula, our own model for how to engage the Latino or Hispanic community. We train on value-based, macro, MIPS, all the other components that are needed. Once you get a capitation payment, how do I manage my time? How do I work with my high-risk members? How do I focus on my high-risk members and still get my work done? We create an incentive system. You can't just walk into an office and say, do this work and do it for free, please, and maybe you'll make some money. We pay our doctors in advance of their share of savings. So we take the risk that we will achieve if they assume the workflows and the training that we ask them to take. And this is a very unusual approach, but it's worked out. Our first year network performance, we saved money in every single contract, value-based contract share of savings we had, and are now in a position to move them to professional capitation because of that. And one client in particular, large client, we saved over 10 basis points in MLR savings on a Medicaid plan, which is very difficult to do. But we can't get there with network. Also our network includes the largest behavioral network and the largest community-based network. These are community-based facilities that do all the good work of the community for, food banks and homeless shelters, et cetera. You have to be able to coordinate care across those dynamics as well. But you can't get there with network only. So we have clinics. We've invested in clinics where we have complex needs. So for complex patients with high-risk comorbidities, we have opioid addiction, we have pain-based primary care and behavioral integrated clinics for those in some tough communities. And then we also have a retail clinic. We put in the first retail clinic into a Hispanic grocer. It has 50 stores across the state, and are seeing tremendous results of capturing weekend crowds, overcoming the machismo factor of not going to the doctor, other things that are fundamental to the population. But it solves an access to care issue. So access to care, complex care needs support. And if you're going to be an integrated delivery system, or you're going to be an organized MSO, you need to be able to take risk on those members and have those services. But that's not enough either. You have to have boots on the ground. So we have ambulatory care teams and community health workers that support the transitions between hospitals and home and other sites of care. That's the provider side. I'll be quickly on the payer side. You have to be able to go tit for tat with the payer, right? You got to be able to have very sophisticated both provider risk, but also knowledge of health plan risk environment. So we triangulate that through our actuarial work and our delegation with the payers, and have a very strong team that negotiates that. You have to have clean data, and as we all know, getting data from a health plan that's what you need is an ongoing task. And so that's something that the industry, I think, will always have to struggle with for a period of the next few years. Hopefully we'll get to a good point there. You have to have technology, I'll talk about in a second, and then you have to have strong member engagement that the payers have confidence that you're going to be able to reach those members in an appropriate way.
That's fascinating. That's all great stuff. Bo, how do you investors look at MSO business models versus physician ownership business models, and is there a valuation arbitrage?
I don't think there's a valuation arbitrage per se. It's really dependent on the company, the sector, the specifics in terms of how they look at it. MSO, in my view, it's a way to help structure these transactions and help create the sort of aligned incentives from an investor and their physician partners in terms of a transaction or a company or an investment. So I don't think there's a real difference per se, but you obviously need to be very careful in terms of how you structure and make sure that economically everyone's aligned and everything kind of lines up with the direction of where things need to head. I will say one of the issues, and I think Hugh was talking about it when he was just speaking, is that, in an owned model, in terms of changing physician behaviors, sometimes that's a little bit easier when there's more of that sort of direct relationship, and that's especially important in value-based care. Especially you take something like primary care, where a physician is used to doing an appointment every 15 minutes, and that's really how they're going to make the amount of volume they need to make a living. Going to those primary care docs and saying, hey, you should actually leave a couple hours a day in your appointment book open so that you can deal with those complex, unexpected situations, that can be a hard mindset change. And if you're in an MSO model, that's maybe a lighter touch type model, or an IPA model where you don't have as much control in terms of helping, do that practice transformation or behavior transformation, sometimes that can be a little bit difficult. But for the most part, I think people will look at them kind of similarly, and it's going to be more down to the specifics.
Yeah, what an amazing comment. So we're involved in a transaction that we completed, and when you talk about behavior modification, it's amazing with the physician mindset. So out of one of the pods that we just did, there's 26 physicians in a community. These are urologists, and 100% of all of their procedures are done in the hospital. So we're saying, hey, we can not only build a center for you, there will be more money driven to both you and to the MSO, both individually and corporately, and you'll have a better quality of life. You'll be out of the hospital. There's no, gunshot cases that are going to knock you off, change your schedule. And the amount of pushback that we've gotten, I almost had to bring in the other 80 physicians in different parts of the state to share with them. Life is so much better, but it's not easy to change the behavior of physicians if they believe, and remember, we're trying to empower them in that, hey, you're making all the clinical decisions, we're just trying to share with you how to be a little more efficient. It doesn't just happen, it's I'll say, by learned behavior, and it sounds like what you're doing is kind of spoon feeding some people along the way to kind of show them, hey, there is a better way to do this. Anyway, the next comment or question I had for you is, what role does the MSO, and you're perfect at this, the MSO technology play in the transition to value-based care?
So for the industry to progress, you have to be able to scale. The payers, there's obviously state-based plans, but in general, we have very large national payers. And what works in one market, they want to work in other markets. It's really hard to say, well, we'll just do this in one state. And that presented a challenge for our business. We've got obviously a pretty big lift from the way I described it, right? And so we're doing our business, what we call the deep model, which is taking on full professional cap, moving to global cap on our MA business in Arizona and California, and we'll be expanding to Texas this year. And those are the 3 states that we've targeted total in our business. However, there's demand for the kind of work that we do, and so we've created what we call platform as a service, where we can offer and teach the payers how to do this themselves, or come in and do it for a period of time and transition ourselves out. But the whole core of that is using technology. So I got very lucky early on and came across the technology I was able to acquire. They had 4 employees, but they were doing a pilot with one of the largest payers in the country for care transition, or for care coordination. And I went, well, geez, care coordination would be really important in the business model I'm building, at least locally. But I didn't realize what they were really building at the time was really a payer-driven care coordination platform that allows payers to coordinate with any community-based provider and other interdisciplinary care team members and set the payer rule set to push that to providers. Half the problem for providers is knowing what am I supposed to work on. My EMR kicks out certain gaps in care. Those aren't the same gaps in care that the payer wants to pay on. Or I've got HCC suspects that I could call on, but I don't know, are these the right ones? Or no, we already had those in our system, right? It's the inability to link payer and provider technology together. So it's the basis of how we will scale our model, but let me tell you, a robust care coordination platform is critical for serving the multiple health needs across multiple types of providers in any given community. HIE, so we pull in massive data from HIEs, over 20 state HIEs. We have 20 million people on the system now at this point, serving the 5 largest payers in the country. And Optum it's a product that Optum is private labeled, as well as part of their suite in Optum Insight. But what this does is it aggregates data from HIEs, all the ADT feeds, admission discharge transfer feeds, so you know who's in the hospital. We extract CCDs, which continuity of care documents, out of over 150 different EMRs, so we can capture encounter data, match it up with ADT data. We can also push stars, HCC suspects to practices, and then also integrate social determinants of health community-based coordination and behavioral-based coordination. Those are 2 recent innovations we just announced in the past 2 weeks. So what that means is I have now ability to transition a patient, have insight into where that patient is going at both the payer level and at the provider level. And then that helps the provider then improve their workflow, where they only have a handful of clicks versus all the referrals, all the calls they have to make, all the paper all the paper pages they have to run through manually to find these community-based organizations to transfer to. One other thing, you wouldn't be able to get adoption for this product if you didn't have a reason for them to do it. So again, we pay them through incentives to use the technology. But what we're finding is it's become very valuable for the doctors because they have, at this point, portal fatigue. So if you're an independent provider, you have to go to 8 different portals to pull down 8 different sets of instructions and information on what you need to do to close gaps in quality and so forth. We consolidate those portals all into a single portal and hit their highest gaps, the highest value gaps for that physician in terms of compensation, to be able to achieve those first in their workflow. So it's a long answer to a very complex topic that I think will grow as visibility comes to this space in the future, that a care management system that a payer buys with a care coordination module that's connected to nothing is not going to solve the long-term needs of providers who have to coordinate care for a patient across multiple domains in an environment. And that's going to continue to be a hardcore need in this country, no doubt about it, especially as MSOs grow.
Well, to me, it's incredible with what you're saying, the depth of it. So my question back to you would be, is how is the average physician compensated in terms of doing all of those things? What kind of money are they making versus if they just practice I'll say the way that they've learned to behave versus, hey, Henry, if they follow my lead, we'll all do better. Could you have some numbers?
So under a share of savings model and us paying those incentives, we're obviously arbitraging the savings, but we're
Right.
betting on them making the savings. In that kind of a model, they won't make a lot. They'll make maybe 10, 20% more than they did. But it's all staging for capitation. So when we can actually subcap the provider, they understand how to arbitrage those workflows, and they change their focus to focus on more of their higher risk members, double, at least on a primary care basis, double income. We've seen that proven out.
Are most of your physicians primary care in these models?
We have a 3,000, so in 3 years we built a network from zero. Actually, I had 3 Hispanic doctors who joined early on and thought I was nuts. But we We've grown from 3 primary care doctors to now about 3,000 in the state of Arizona. A combination of specialist network and primary care, but of those 1,300 primary care, of which 1,100 are MDs or DOs, so mostly primary care based, not just advanced practitioners. And you know, I think it comes back to the simple value proposition of I, on my own, can't get there. I can't even get a value-based contract. I'm going to be left out of future value-based contracts if I don't partner up with a group to help me get there. And I think you're going to see more and more of that by market. But a loosely affiliated IPA structure that doesn't do anything to change the practice and help educate the practice on what to do is going to have a hard time winning, I think, in the future.
I would agree, and I think you starting in an underserved, underprivileged area is more difficult. I think taking that model and bringing it to more of a middle America affluent community could be awesome.
Yeah, can I comment on that? So that's how we started, but what's happened is, starting really with this simple factor, our health plan said, wow, you take our red and yellow practices to green. I don't care what line of business, what other lines of business can you do with us and do that? So obviously there's different, and we have a care model for our senior population, and we do have 3 Medicare Advantage contracts. We'll have 1 large one going to global cap this next year, and we are building it out for that exact same thing, where it's not as much the cultural competence, but it is understanding, you know, in that case, the care continuum, post-acute care, other issues. We're building a product with one of the Blues plans around a dedicated commercial product also for the Latino workforce. So we're expanding product lines as we grow.
So will you look to monetize this?
We're heads down building a great business.
All right. Well, call me when you're ready.
Call me instead.
Bo, so what's the difference between what the current relationship in terms of the wave of MSOs and what occurred in the 1990s?
Yeah, I mean, I think it's ancient history at this point, but most of us are aware of what happened in the 90s. There was a big wave of this physician consolidation, a lot of IPOs and public company stories, most, you know, and some high-profile failures as well. I think those models, it was all just purely about the consolidation, about the arbitrage between what you could buy at, what the platform was valued at, and there weren't all these value-add type services that the platform or the MSO was providing. So you didn't have the data and analytics. There wasn't really a notion of value-based care and all the things you can deliver with that. And then just a lot of the other technology that they were putting forth in those days was very minimal compared to kind of the robust technology that exists. And all the regulatory and payer stuff is just much more complex than it was back then. And I think what you saw back then was it was a very light touch. The accounts receivable and revenue cycle management capabilities of some of these platform companies weren't very strong, and that's where they really ran into issues as they were doing this consolidation and just couldn't really manage that piece of the business, which ended up resulting in you know, a lot of issues and some high-profile failures.
So I got in the business in the 90s, actually 1990, and we saw what went on. And I mean, it was unbelievable to me. A practice would be bought, the company would go public, and literally within 90, 100 days, they filed bankruptcy. I mean, you can't make this stuff up. I mean, and I don't think that's going to repeat itself. I think people are a way lot smarter today than they were then. I saw hospitals employ physicians. I mean, it doesn't work with a traditional model. There has to be aligned incentives. So hopefully, you know, we won't see that disaster again. So we have about 5 minutes left, and I thought this might be a good time. We got some great panelists up here to ask any questions of them that you might have. So by a show of hands. Yes, the woman in the middle. Somebody's coming right with a microphone.
I wrote it down just so I could concentrate. Do you see a huge, do you see the huge mergers in the payer space impacting the growth of the MSO market or changing the MSO growth strategy?
Both of you can weigh in.
And by huge mergers in the payer space, I mean Centene and WellCare, those types of.
So we're actually in negotiations with both for capitation contracts at this moment. So we have a 10/1 start date in Arizona for Medicaid. So right now it's been a little bit of wink, wink, make sure the deals line up similarly. This is obviously pre-approval that just happened, but it will, I think what it will ultimately do, I don't know in the near term, but ultimately it will lead to what this industry will likely end up with, which is consolidation. Will it be an Equality Health out there, or will it be an Optum out there doing these types of negotiations? I mean, that's just how I think about it anyways, is that while these platforms need to get developed and started in this MSO space, and not be so highly regional, which they may have to be. It may just have to be an aggregation of regional approaches, but it will take a larger aggregator to be able to sit at that table and negotiate those types of incentives and contracts with these payers over time. But we've still got a lot of runway, I think, before that happens. At least that's my opinion.
Yeah, no, I agree with you, and I think you'll see it'll help actually drive the industry, because I think the payers are recognizing that these companies are more sophisticated and can deliver more value to them over time if the right relationship is established. And it's not just, I want higher rates, and no, I'm going to give you more volume, you're going to take lower rates. That friction will still exist to some extent, but I think more of a partnership model will develop, and then you get into value-based arrangements. And I think, look, some of these payers are very interested in these MSO models on their own, and so they're going to be acquirers of a lot of these businesses over time as they look to do vertical integration. And I think especially in terms of value-based care, they're not going to want to cede a lot of those economics and purely become a claims processing engine. They're going to want to be involved in these value-based arrangements in a big way.
We've seen actual contracts with some of the managed care players where they don't want to see you add more than 5 or 10 physicians in any one time. So they're very concerned, but it's changing the landscape. Everybody's getting a little more sophisticated. I mean, Optum, I think, has 15,000 physicians today.
They're the biggest provider organization, I think, from a physician standpoint.
Unreal. We have time for one more question. Yes, sir. And the man with the bow tie.
I lost the chance for $100. All right. So MSO platform clearly was designed to solve multiple problems. What one problem you would say that it has solved that was significant enough so far, and what problem in future is most important or most impactful that needs to be solved by MSO to be a proven model to continue?
Bo?
Yeah, no, that's a great question. I mean, I think to me, the one thing it really solves is the ability to really create these platforms or partnerships in a structure that is, compliant from a legal and a regulatory perspective, and then creates all these value-add services that we've all talked about. I think in terms of the problem, it's, I think when they're done in a way that doesn't align the incentives and it's more just structural than actually adding any of these value-based or technology or other issues, that's where it's not going to create a lot of value for anyone, including the physicians. And so I think the lighter touch MSO models are the ones I think are going to have the issues. I don't know, Hugh, if you have a point of view.
Yeah, it's definitely alignment of incentives. So, we have amazing relationships with our payers, and we have amazing relationships with our practices. So that tells you right there you've got a value proposition. The complexity that's involved on each side that either side doesn't really have clean insight into is why that value exists. So when we talk to most of our independent providers and we start talking about the complexity we get into a risk negotiation, they're like, I'm good, thanks, just get me the best deal, right? And same thing when we talk about the complexity of the delivery system and the components that we're putting together to drive to better outcomes. The payers can go so far, and they need us to do the rest. So I think it is that the single most thing is that huge alignment incentives driven by the change in payment.
Well, thank you. Thank you all for listening to us. I want to thank Bo and you for your great insight. Thanks a lot.
Thanks, Henry.
Thank you.